We're going to be looking at adapting practices at the point of service delivery and how that can support aging in place. It's likely that as you develop person-centered plans and discuss an individual's wishes around where they would like to age and what things are most important to them, you will see that people prefer to remain in places that are most familiar to them. And they probably will not select that they would like to move to a different or a new home. So we're going to discuss how individuals can be supported to age in place when this is their choice.
Aging in place, the ability to live in one's home and community safely, independently, and comfortably, regardless of age, income, or ability.
And this is a definition that's provided by the Centers for Disease Control, the CDC, so you can access that online.
And aging in place principles means individual planning, continuity of personal relationships, continuity of community. So you're staying in the same environment with the same friends that you want to be near, family that you want to be near, and integration with generic supports. And those supports can be adaptive equipment, ramps, a variety of different things to make an environment safe. Now Jill is going to talk about safety.
So safety really has to come first, and it's a primary goal in supporting a person to age in place. Safety considerations include that resources are in place to minimize the risk of falling, compensate for diminished sight and hearing, routines that are understandable and predictable. You want to develop fire safety, such as flashing strobes and bed shakers. You also want to consider safe relationships, make sure that family members, peers, and caregivers understand how aging is affecting the person's abilities and behaviors. You want to evaluate the community that the person spends time in. If the person goes to a day program or to a work site, make sure that there are environmental modifications in place there so that there's sufficient protective oversight as the person's, as his mobility, as his visual and vision and his hearing may be declining. You want to create safe environments for individuals to sustain mobility and functional abilities. And this could include ramps, wider doorways, raised toilet seats, and tub rails. Remember that because of the Americans with Disability Act, these can be provided at places that are not necessarily designed to meet the needs of someone with disabilities. That the person is working in a community location, you can request that accessibility be provided for the individual. You also want to look at lighting for people with dementia and visual impairments, avoid patterns in the flooring, reduce shadows, address depth perception, and issues around stairs by using reflective strips on stairs or on uneven flooring. You want to pay attention to assuring opportunities for privacy and quiet and calm moments so that the person can spend time and avoid confusion associated with a lot of noise and activity. This is particularly important for people living in even small congregate care settings where noise and busyness is a part of everyday life. These can be too stimulating, and they can be upsetting to the person. The person can also feel that it's like too much if they're just having like a difficult day. Room dividers can also help with this by creating spaces for privacy and one-on-one activities.
To keep the home understandable, avoid confusing layouts, provide cues to navigate. Some people learn how to navigate because a particular end table and a particular chair and certain walkways that they walk through, they use those as their cues of how to navigate around the room. Changing layouts can also be very confusing. Use adequate lighting and limit disruptive noises. Select sturdy, simple, and versatile furniture. Secure lightweight objects such as lamps. It's very easy to knock a lamp over and trip someone. So secure them. Make it something that's either heavy enough to not be knocked over or secured to the table. Use red or yellow. They're more accurately perceived than darker colors. And I could speak to that also. I have a pair of glasses that are dark rimmed, and as an experiment, I put them on my black granite countertop. I don't have dementia, but I really had a difficult time seeing them. But if I put them on my table that was a light oak, there was no problem finding them. So things can blend into, it's something to consider. Don't put an object that's going to blend into the background if someone needs to be able to easily access that object. And use large print signs to label familiar items.
So in home safety, you want to address clutter and trip hazards. Avoid confusing layouts, as Linda was saying. You want to install railings and hand grips at the top of stairs or at a stairway. Use reflective tape to call attention to steps. If it's possible, replace the steps with ramps. Use adequate lighting. Limit disruptive noises. Replace door sills with flat plates. And it's probably most important of all, keep areas free of clutter. That's a huge issue with people who are aging. Somebody is living in a house that has stairs that he has to navigate daily. Make sure that things aren't left on the stairs that he might trip over. For people who are losing their vision, you can also access information from the American Council of the Blind, which will provide you with resources and additional information about making a living area accessible for somebody with a visual impairment. They have a specific area that's for seniors who have been sighted for most of their lives and are losing their vision associated with aging. Be particularly alert to fall risks. This information is coming from the CDC. You can see the website listed there, www.cdc.gov. And I really encourage you to visit that site and in the search part of it, just type in older adults or seniors. It's just a wealth of information. Falls are the leading cause of fatal and non-fatal injuries for people who are older, and most falls can be preventable. Most fractures in older adults are caused by falls, and somebody who's older and may be experiencing osteoporosis may take a long time to recover from a fracture. They may develop secondary illnesses as a result of the fracture, so you want to avoid those. The most common fractures are spine, hip, leg, arm, and pelvis. And we're going to be looking at ways that you can evaluate an individual for their risk of fall.
Yeah, one other thing I just wanted to add, with someone with an intellectual disability, sometimes recovering from a fracture and regaining their ability to walk is very difficult to regain. We had a young lady with Down syndrome on our caseload that fell, fractured her hip, and she went to subacute rehab, and she never regained her ability to walk. Physically, she was capable of walking, but she had gotten so used to being in a wheelchair and wheeled around, and I was so frightened of standing on her leg after the fracture that she just never retrieved that ability to ambulate again, and ultimately ended up not being able to get back to the home she came from because it was a home with stairs and she had to be able to ambulate. We had to reconsider her environment. Anyways, why do fall risks increase? Falls, the risk of a fall increases with vision changes as you age, glaucoma, cataracts, diabetic retinopathy, or just simply not wearing your glasses to see where you're going. It's very important when someone goes to bed, make sure those glasses are right next to the bed, because as you age, sometimes you want to get up more frequently to go to the bathroom. If those glasses aren't close by, you're not going to use it, and it increases the possibility of a fall risk. Medications, sedatives, diuretics, blood pressure meds, muscle relaxers are common meds as you age. And they all have, sedatives. You're too sedated sometimes, to be able to ambulate independently at night. Someone needs to be aware that maybe you should have a call bell there, or someone checking to see if someone needs a bathroom trip during the night, depending on what type of home setting someone is in. Diuretics make urination more frequent. Lack of exercise can lead to muscle weakness, some atrophy of muscle, so your strength is diminished, so your capability of walking is diminished. You can still walk, but you may need to walk with assistive devices. And not using assistive devices that you need at night is also a frequent problem. Put on the right shoes. Don't just throw on these like slippers that don't quite fit right and you're scuffling along. It's a trip hazard. If you need a walker or a cane to ambulate, it should be nearby. So if you needed a bathroom trip in the middle of the night, it was possible. And people with IDDD may not understand the dynamics of aging, so you need to consider safety first always.
And I think to the degree that you can partner with the individual in discussing how to protect themselves, again, we're talking about coming from a strength-based focus. So you want to work with the person on preserving the strengths that he has. And ambulation is a huge asset as you age. So, encourage the person to think first, to think about safety before they get out of bed and ignore the walker or ignore the cane, or as Linda said, put on the comfy slippers instead of something that really supports ambulation.
Okay, to minimize fall risk, make sure there's proper lighting, avoid cluttered spaces, provide handrails and grab bars, secure area rugs, or don't use area rugs because they're such a big trip hazard. Secure electrical cords. It's so common to see electrical cords run from the couch to the chair 2 feet away or 3 feet away, and someone walks in between there. That's a trip hazard. Run them behind furniture, along the wall spaces, not across room spaces that someone has to pass. Keep eyeglasses, like Jill said, assistive devices close to the person, and encourage their use. Do weight-bearing exercises to strengthen someone. Take calcium, vitamin D, to screen for osteoporosis, which increases a fracture with a fall, the risk of a fracture with a fall. And peer support to talk about what's happening to me. I'm aging, things are different. I don't see as well. Do you have this problem too?
So you want to assess fall risks regularly. This graphic was adapted from the CDC. When you're looking at people to identify who is at risk for falling, you want to consider if they've fallen in the past year, if they feel unsteady when they're walking or standing, or even if they just worry that they're going to fall. It's probably indicative that they may be at risk. So at that point, you want to have their gait, their strength, and their balance evaluated. And then if there is no problem, when you have a nurse or another medical professional evaluate them, then you want to make sure the person is educated and has the opportunity to go to some exercise programs where they can work on balance, on fitness, and fall prevention. These are not really rehab programs, but they're preventive programs, and they're incredibly valuable. They are really helpful, and they can really preserve the person's strength, and in doing so, preserve the person's ability to stay at home in a living situation that they prefer.
This is a chart to indicate ways to respond to gait or balance problems based on number of falls. If someone had no falls in the past year, like Jill said, you're going to educate the person, refer for gait or balance retraining or fall prevention programs, just because they may have some criteria that puts them at risk. If a person has one fall in the past year, determine the circumstance of the fall. Was it just a simple accident that may not reoccur, or is it because they have a vision loss or a change in mobility that is putting them at a higher risk of falling? Or do they have osteoporosis? Have you assessed the reasons that contributed to the fall? And once you've determined that, conduct a risk assessment, fall history, physical exam, postural hypertension could be a problem, postural dizziness, cognitive screening, is there a change in mental status? Review the meds that person's taking. Are they taking things that could make them drowsy and they fall? Or are they confused? Proper footwear, like we talked about before. Assess what they're wearing. You have to look at all these things. Mobility aids, access to their mobility aids. Do they need mobility aids, and are they readily available, easy to get to? And visual acuity. If you have more than 2 falls or a fall injury, again, determine the circumstances and go back and do a risk assessment. And your key interventions, going back to that, are education of the person, education of the caretaker, enhancing strength and balance, improving functional mobility, managing myths, addressing foot problems, Adding vitamin D and calcium, optimizing vision with glasses, optimize home safety. Okay, you can turn it now. The CDC has a nice fall risk checklist that you can, I think we provide the PDF on that?
Yes, you should have that PDF in your...
Okay, well, if you look at that, it's a simple form to assess, what the risks are. Looking at fall history like we've talked about, and it's a yes or no check off. Has there been any falls? If there has been, please note them in the section next to it. Worries about falling or feels unsteady, they're scared when they're standing or walking, indicate it. It's a yes or no. Medical conditions, these are all things that can contribute to fall problems, so you want to know if they exist. Heart rate problems, arrhythmia problems, cognitive impairment, incontinence, depression, foot problems. Surgery sometimes can correct the reason why you're having a fall problem because you have an anomaly with your feet. Other medical conditions, cerebral palsy, these are all things that as you age, cerebral palsy brings more mobility issues. So you're noting that. Like I said, medications can contribute. So what medications are they on? Are they on psychotropic meds? Are they on sedatives? Are they on anticholinergics? Are they on diuretics that would make them go more frequently to the bathroom? And then there's gait strength and balance. There's several tests we're going to talk to as we go along of how to assess gait strength and balance, and we'll review those tests in a moment. Vision acuity, less than 20/40 or no eye exam in the past year, you want to note that. Maybe it's time to send someone for an eye exam. Postural hypertension is a decrease in the systolic BP, and the change when you go to stand up. Postural hypertension means when you're standing up, you're feeling a little lightheaded or dizzy, and then that's a fall risk. So, and like I said, you have the PDF, so you can take a look at it that way.
So we didn't include these tests that we're going to go over now in the PDF, but they're very accessible from the CDC. What you can do is you go to the cdc.gov website, and then you type in STEADY, which is an acronym for Stopping Elderly Accidents, Deaths, and Injuries. And there's a whole toolkit that you can download and use in your practice. One of the tests that we're going to look at is the TUG test. And this is kind of a mini evaluation. It may not be something to use as a diagnosis tool, but it can certainly be something that's an indicator. And depending on what you discover in doing this, you would want to refer that person to a healthcare professional. So the directions are you're going to use a stopwatch, or if you have a smartphone, you can use that. That's what I would use. And you're going to ask the person to wear his regular footwear. And if they normally use a walking aid, they can use that as well. And you're going to begin by having the person sit back in a standard armchair and identify a line about 10 feet away on the floor. Then you say to the person, when I say go, I want you to stand up from the chair, walk to the line on the floor at your normal pace, turn, and walk back to the chair at your normal pace, and sit down again. And as soon as you say go and the person begins to get up, you're going to start your stopwatch, and you're going to time them. And somebody who takes more than 12 seconds to complete this test is at high risk for falling, so you're going to want to refer them further. You're going to be looking at the person's postural stability, the way their gait is. Is it a regular gait, or does it seem like they're struggling? What's their stride length? Are they walking with good, adequate steps, or are they shuffling? And if there's any sway, does it seem like their balance is compromised? And then at the bottom, as you can see, you want to circle anything that you think is a concern. Slow tentative pace, loss of balance, if they're taking very short strides, or as I said, shuffling, if they're not swinging their arms, if they're using supports like walls or furniture, if they're like on block turning. How would you explain what that is? Yeah, like maybe turning in an odd fashion. I don't really know how to explain that. So, there's probably not enough space on the camera for us to get up and demonstrate. Or if they do have an assisted device, if they're not using it properly, if they have a walker, if they're kind of, grabbing onto it and not really, putting their weight forward, and then there's a risk that they're going to fall backwards. So you're going to want to make note of all of that.
You want to make sure you're using an armchair, though, because you're looking at people that are aging. There may be a knee replacement, something they're allowed to push up on the arms of the chair and may need to do so to be, and that's an acceptable part of that test. You shouldn't be using a walker to pull yourself up. You push on an armchair, you come to a standing upright position, and then you can utilize your walker or your cane or no device.
So now would this be like a straight chair, like a dining room
like
chair
we're sitting in right now,
or like an office chair?
A straight chair with arms, and you can push up on those arms, and that's an acceptable piece of the
But
test.
it wouldn't be an easy chair, so it would be too hard to get up on it.
Yeah.
Now we're going to talk about the 4-stage balance test.
Okay, and this is to assess static balance, which is standing still balance. You're going to need a stopwatch. There are 4 progressively more challenging positions. Patients should not use an assisted device for this particular test, like your cane or your walker, and you want to keep their eyes open. Describe and demonstrate each position. Stand next to the patient, hold his or her arm, and help them assume the correct foot position. When the patient is steady, let go, but remain ready to catch that person in the event that they did lose their balance. If the patient can hold a position for 10 seconds without moving his or her feet or needing support, go to the next position. If not, stop the test at that point. You're going to, at each stage, you're going to say, ready, begin, and start timing the 10 seconds till you say stop. You're going to demonstrate those 4 positions, and what those 4 positions are. There's actually another page that you can print off of the cdc.gov site when you put in.
When you download it, it's a 2-page.
Yeah, and I don't believe we didn't put it in the PDF.
I don't think we included it.
Yeah, we didn't include the second piece. But the positions you're testing for, and only if they can progress from one to the others, stand with both feet side by side. And you're counting your 10 seconds. The next position will be place the instep of one foot so it is touching the big toe of the other foot. And if you can stand in that position for 10 seconds without falling over, you can move on to the next. The third position is to place one foot in front of the other and stand. And the 4th position is to stand on one foot, your right or your left, and count your 10 seconds. If you can maintain the balance, you're doing well. Okay, the next one is the chair stand test we're going to review.
Okay, this is the 30-second chair stand test, and this is going to be testing leg strength and endurance. So you want to get a chair with a straight back, so it would be like a dining chair, but it doesn't have armrests, and it should be about 17 inches high. And again, you need a stopwatch or a smartphone with that app on it. You have the person sit in the middle of the chair and then place their arms on the opposite shoulder crossed at the wrists. They're supposed to keep their feet flat on the floor, keep their back straight, and keep their arms straight against their chest. And when you say go, you're going to ask them to come to a full standing position. Again, they're not going to be using their hands to push themselves up from the chair. And you're going to have them repeat this for 30 seconds. If the person has to use their arms to stand up, then stop the test because they're just not able to do it and they're at risk. Count the number of times that the person is able to sit down and come to a full standing position in 30 seconds. And if the patient is over halfway to a standing position when the 30 seconds have elapsed, then you can count it as a stand. And then there's a space to record the number of times they're able to stand up. And then this again is, when you look at this on the CDC website, this is a 2-page PDF. So for someone who is age 60 to 64, they have a whole chart that goes over it. They break down how many times the person should be able to come to a standing position with their arms crossed at the wrist and holding on to their shoulders. For somebody 60 to 64, they should be able to do it at least 14 times if they're a man, and at least 12 times if they're a woman, and that kind of decreases with age. So between the ages of 90 and 94, if a man should be able to do it at least 7 times, and a woman at least 4.
But the thing is, these are tests that are indicators. They're not absolutes. They indicate that maybe you should refer someone to an occupational therapist, a physical therapist, a doctor, for further evaluations. These are just tests that you can do in your practice that are indicators.
They're more like screens. So if you're concerned, if you've been talking to somebody and they say, well, I don't like to go out anymore because I'm afraid I'm going to fall, this might be a way of partnering with them to kind of evaluate whether you need to take that to the next step. And again, you want to work collaboratively with the people on your team and the people in that circle of support to make sure that the person has expressed a concern about falling and that you're looking at doing some screening and maybe referring the person further.
Okay, now we're going to go on to home safety in bathrooms. Safety rails, shower tub rails are helpful. A raised toilet seat or a bar on the wall that to assist with getting upright. Walk-in showers, use of a shower chair in your bathroom. Shower mats that have little suction cups to, so you don't slip. Adjustable shower hoses and nozzles, so if you were using a shower chair, you can take the shower and hose. And skull protection devices in the shower. So for someone who has less sensation, so they avoid burning, because they may not know they're being scalded.
Safety in the bedroom. I'm going to talk about avoiding falls at night. They're extremely common, as we've been discussing. People often need to get up to use the bathroom, and they may not put their glasses on. They may not use their their walking aids. So we want to be as safe as possible in the bedroom. Some of the things that you can do to assure safety is to remove the wheels from the bed. If it's like one of those metal bed frames that has wheels. If you can't remove them, you can also lock them. Depending on the person's needs, you may want to get an adjustable height hospital bed. Install a bedside lamp. That's like probably something you should have in any case. So that the person can turn the light on if they need to get up in the middle of the night. And if they're, someone who likes to lie in bed and watch TV and listen to the radio until they fall asleep, have remote control switches nearby for the radio and the TV. An intercom or a bedside phone can be really helpful if the person does need help getting out of bed, or if the person really has some issues with mobility and is really compromised about getting up at night. You might want to keep a urinal or commode at the bedside. Home safety in the kitchen. Again, the focus here is to maintain independence and functional abilities as long as possible. You want to assure safety without limiting autonomy, and it really is a balancing act. The important thing to remember is that putting these supports in place, you want to do that with the person included in those decisions. Talk about why you're doing it, and that someone who's been living in their own apartment doesn't feel like they're being diminished or disrespected if you start putting things like an auto shut-off for electronics, or if you suggest that maybe they should have Meals on Wheels come, every once a day. So you really want to make this a partnership. Some of the other things to consider are to put things that they use commonly or most often in easy reach, so they're not having to go up and down the step ladder or strain to reach a high shelf. Increase the number of lights. It's preferable, of course, to have lighter countertops so that, if they do put something down on the counters, they can see them. As Linda was explaining, that can be a challenge for someone who is experiencing declining vision. Use contrasting colors in china or placemats. Some of these things are supports, but they also make the environment more pleasant. It makes, it more likely that the person is going to sit down and enjoy a meal because they can see everything. Use bright colored handles on the utensils, for example. And when you're doing this, you're helping the person to really think actively about safety and what he or she can contribute to maintaining their personal safety.
Things to do to keep for safety in the living room area. Automatic seat lift chairs, recliner, so you're remotely pressing a button that brings you upright, so that you're not struggling to get upright and ambulate across the room. Good armrest to push up on. firm back and seat cushions. Avoid rocking chairs because of the fall risk of a moving chair. Relocate furniture so pathways are not obstructed. Touch-sensitive light switches, contrast color for light switch lights is useful. Next one. For managing stairs, you can use stair lifts or ramps if necessary. Make sure there's handrails to hold on to when going up and down steps. If you're unable to climb stairs, keep a second walker available at the top or bottom of the stairs. So if you're using a stair chair to get up and then you need a walker to walk with, have one at the top and the bottom of the stairs so that you're not trying to carry this walker in your chairmaster going up the stairs and creating another kind of trip hazard. Remove loose rugs, or just don't use throw rugs at this point in time if there's a trip hazard. Mark edges of each step with a bright colored tape, which we've discussed before. People may lose depth perception due to cataracts or glaucoma. Highlight those step edges to make them more visible. And that's, basically it. Fire safety.
You want to assure fire safety for someone who's losing hearing or has a visual impairment. You might want to have blinking lights or vibrating surfaces so that the person wakes up if the fire alarm goes off. You also want to provide an alternate exit in case of emergency. And you want to practice that fire drill plan. And in thinking about alternative exits, make sure that they're really accessible to somebody who may have trouble with mobility. If they're exiting from a doorway that is usually it's like a ramp or something, make sure that that's kept clear of ice and snow, and have them practice on it so that they're aware of, if this area is blocked and I can't go out the front door, then I need to go to this other exit. And I don't think you can practice it too frequently, especially if people get confused easily. You want to provide adequate lighting on stairs and in hallways. Make sure that you have night lights, and always make sure that the bulbs are changed on a regular basis. And use lever door handles instead of doorknobs because they open more easily.
Wandering sometimes becomes a problem as people age. So there's medical alert programs in community settings. There's wander guards or bed chair alarms in hospitals or rehab facilities. Provide supervision and or secure areas to walk indoors and outdoors so someone doesn't feel like they're trapped and they can still get to see other places and get to move about freely without feeling trapped. Keep the person involved in activities, redirect pacing or restless behavior, and use calming techniques, quiet areas, music, arts and crafts, simple things to do.
So as the person ages, you're going to change the focus of habilitation. As the person's needs increase, their skills are going to decline. And the programs that are going to work best for people, the sustainable programs, are those that are designed to accommodate changing needs. Remember that your focus is really maintaining the skills that the person has. When you're designing activities that the person is going to work on, you want to think more about memory-appropriate activities instead of age-appropriate activities. Again, don't try to teach new skills. That's going to probably, for somebody, particularly somebody who's experiencing cognitive issues, it's going to be very frustrating, and it's going to be something that it makes the person feel less than he used to be. It's going to really highlight that he's losing skills. So you want to, again, maintain skills and really focus on providing activities that are enjoyable versus activities that require really active participation. You don't want to force the person to do anything, but you want to engage the person in things that he or she likes to do. And again, as the person ages, familiar routines and settings become more important than ever. So to the extent that you can, provide those habilitation services in an area that's familiar to the individual.
Some other considerations when taking meds: declining skills may affect a person's ability to self-medicate, and they may need additional supports. Memory loss is difficult to remember. To take meds, you can use pill boxes or reminder calls. Set an alarm that goes off at the time you're supposed to take that med. Impaired vision means difficulty reading labels, so use larger print, larger labels, bigger numbers for amount of medicine to take. Dexterity becomes a difference. You may have difficulty opening bottles and an inability to break tablets or difficulty handling inhalers. So they may need additional help with those things. And they may have difficulty swallowing large tablets or capsules. So they may, some pills can be crushed in an applesauce and taken that way. Some pills are enteric coated; they can't be crushed, but they can be taken with some ice cream to make them slide down a little more easily, because they have to be a whole pill. Additional considerations for supporting a person to age in place include supports around the person's self-medication skills, and scheduling many different meds throughout the day can be very confusing, so try to unite those meds into schedules where they're more condensed into shorter time periods, less amounts of time.
And in that situation, you're going to want to partner very closely with the person's doctor, so that, in some cases, maybe the person can't swallow a large tablet or capsule. Maybe that medication is available as a liquid or in a different form.
Or now there's a lot of meds that come as an absorbed tablet. A tablet will absorb under your tongue. I mean, there are sometimes other choices, and that's a good point.
So, as we mentioned earlier, the demographics of caregivers are also changing, and the person's ability to age in place may be seriously affected by the age of his or her caregiver. 65.7 million, or 29% of the United States population, are caregivers of somebody who is ill or disabled. It's not necessarily somebody with an intellectual disability, but it is a significant number of people who are providing care to a family member. And many of these caregivers are over 63, and they may be facing their own health issues. And again, what you want to avoid is a situation where you have kind of a two-generation elderly family where the caregiver and the care recipient are both experiencing issues around aging, and they're not really able to work together anymore. In some cases, the child is actually providing care for the parent. So by 2030, the expectation is that there are going to be 641,000 people with intellectual disabilities. Well, actually, that's what it is now, and that's expected to double by 2030. So that's why these issues are things that are very, very current, and why it's so important to be aware of them and to be thinking about the supports that are going to be provided. 49% of the aging caregivers report that they must use assistance themselves in order to continue providing care. So in working with caregivers, those are conversations you're going to want to start having as soon as possible. And you do this by engaging caregivers in conversations and kind of gradually introducing into that conversation what it is that they're worried about. Talk about maybe their ability to provide care is becoming reduced. Is it increasingly difficult for them to take care of the person because their own needs are so huge? Do they have personal health care concerns? Does the caregiver find himself being really emotionally or physically exhausted as a result of giving care? If the person is in a relationship with somebody that they're providing care to, but all of their energy is into assuring that person is safe and providing care to the person, it really impacts the quality of the relationship. And that's another consideration. It's of course a sensitive issue. It's going to be difficult for you as a practitioner to negotiate with somebody, but it is important because you don't want it to be a crisis. You don't want the parent or the caregiver to have a sudden health crisis, and then the individual who is receiving care really feels abandoned or that it's their fault. So you want to make sure that there are enough community supports in place and that you've already planned for other residential options and other supports in the event that the caregiver can no longer provide care. So you also want to help caregivers understand what the person is going through and to teach strategies to support and preserve the person's strengths. And again, these are the things that we've been talking about, but in this situation, you're actually approaching them as teaching the caregiver. You want to talk about how the caregiver should be individualizing activities based on the person's changing needs, to encourage them to provide activities that are calming and stimulating. The aging individual may no longer want to go shopping with the parent. It may just be too much, maybe just confusing, and the caregiver needs to understand that those things may need to change. You can also talk about simple exercises that are most effective in supporting an individual, like music or art or even aromatherapy.
And how can you help caregivers plan for alternatives? Ask them. Are there siblings that can take over? Person's brother or sister, can they take on the care when that aging parent is no longer able to provide care? What are the availability of alternate caregivers, like someone to give you a break, someone that can come in and take over, so you can go shopping, go to the, go get a few items from Macy's or wherever, or just to have a little breathing room, a little time to yourself. Do you have an alternate that takes over? Placement plan in the event of illness or death of a caregiver. Like we talked about earlier, with Jeff's father went into the hospital for cardiac surgery, his sister took over. It was an adjustment for both of them. Community supports to continue the current placement can be looked into.
So there are many companion services in various communities, and those may be helpful to a caregiver if somebody could just come, as Linda was saying, to come and spend an hour or two so that the caregiver is able to get out and do some shopping or have lunch with friends. So one of the ways that you can initiate these discussions with caregivers is to always include them as part of person-centered planning, so that consideration of future supports and providing something that is sustainable and viable is always part of a conversation. And then you can also be considering the caregiver's concerns as part of their their everyday care, and encourage them to identify what they want for the person that they're caring for, but also what they want for themselves. Has their plan always been to retire and move someplace warmer, for example? What are their own health care issues? And again, as Linda said, talk about what their plans are for their family members' care. Who's going to take care of them if they're no longer able to do so? And this is something that can be discussed and planned over time. It doesn't need to be decided immediately. Help the family member develop a wish list and to prioritize and actualize the wishes that they have on it. And it should be wishes that are not just for the person they're giving care for, but their own personal wishes, because quality of life, as we've been saying, it's a balancing act. It's a two-way street. If the caregiver is unhealthy or ill or not happy, it's not going to be a good placement or a good situation for the individual either. And again, collaborate to identify what community resources are available. There's a lot of supports that are out there for the elderly, and these are things that you can make use of.
There's also the caregivers when they're aging. Some of these caregivers that have had people with IDD in their homes for 25 years, they consider them their best friend. We had one caregiver that was aging and no longer really able to take care of this person any longer, but she didn't want to let her go. This was her friend. We had to take that into consideration when we ended up helping her realize that she was no longer able to provide that care, but we would help her maintain that contact with the person that no longer could be cared for in her home.
That's a really good point. You want to talk about how to sustain a relationship. And again, with identifying community resources, the resources you're looking for do not necessarily have to be specifically designed for somebody with an intellectual disability. There are resources that may be completely appropriate for what that person needs. And again, you're coming from that strength-based focus. It can be, perfectly reasonable for what the person needs in terms of some additional supports during the day. And many times the day activities that are designed for seniors are perfectly appropriate for someone with an intellectual disability who's also aging. So we're going to tell you a story now about a woman named Louise, and her wishes for a party with a cake and yellow icing. I'm going to let Linda tell the story.
Louise was diagnosed with multiple issues. She had a right-sided heart failure, pulmonary edema, many physical anomalies, including a scoliosis and a kyphosis, which was impacting her breathing with all the other problems associated. And at this point in time, Louise had reached a point where she had a very limited amount of time to live. She was essentially terminally ill. Her greatest wish was to stay and die at home with the caretaker, in the caretaker's home, and did her caretaker for many, many years. But unfortunately, this particular caregiver could not handle someone dying in her home. She had her own superstitious beliefs. It was just something she could not do, no matter, even though as much as she loved Louise, it was just something she could not give her. So we had to work with Louise to help her understand that this was something that was not going to be possible. But she made it very clear she didn't want to go to a nursing home. We took her to one just to see what it was like. It was not for her. It was not where she had lived in the community her whole life. She had worked in the community. She was only mild intellectual disability and very verbal and aware of what was going on around her. And it was a big grief for her to deal with, that she could not stay in the home that she knew so well. So to help her, we started looking for choices that she was going to be comfortable with. We found a caregiver that we introduced Louise to. She felt comfortable with her, and this particular person was able to keep her in the same work setting, keep her near her friends, and would allow her the ability to choose hospice and die at home, which was her wish. So we were able to support her choices, and we involved hospice. We worked with the hospice team to set up a DNR. She was determined she had capacity to make that choice, and her greatest wish was to be able to have time to go say goodbye to all her friends in her work setting, which we did. We accommodated Louise. We took her to her program. She knew it was imminent, death was imminent, but we were able to take her in a wheelchair to make her goodbyes. And her other great wish was she always talked about having a cake with yellow icing for her birthday, and this was around her birthday. And we knew that death was probably coming soon. So we got all Louise's friends and caretakers and the people she loved to the caregiver's home, and we brought in her special birthday cake. She really couldn't eat much of it, but she had her last wish granted, and did finally pass on that night. But we were able to give her her birthday cake. It was her last thing she wished to have. And by working around what we could give her and helping her understand what her caregiver that she lived with so many years wasn't able to offer her, she was able to move on and make her farewells, and that was what happened to Louise.
The thing that I remember about is that Louise really died with dignity, and I was at her last birthday party with the cake and the yellow icing, and as ill as Louise was, she didn't know me well, and she knew, she was very aware. She didn't have any dementia or diminished cognitive capacity. She made such an effort to get to know me and to express her gratitude that I had come to her party. It was an amazing experience. And then, as Linda said, she died that night. It was very sad to say goodbye to her, but it was also, a kind of a warm feeling because she had been able to have her wishes honored. I do have a hand raised from Mary Smith. Mary, I'm going to unmute you now.
I'm going to.
Mary, you're unmuted. If you'd like to ask your question, go ahead right now.
Hello, Mary.
Dosh.
Mary, we're not able to hear you. Can you type your question in? Mary, it says that you're self-muted. So let's see. Mary, can you type your question, please? Okay, thanks, Mary. No more questions. Okay. So we're going to take the next little while to talk about how to manage specific issues using person-centered approaches. And this is kind of in line with adapting services at the point of service delivery. Bereavement is a natural part of growing older. As we age, it's increasingly likely that we're going to experience painful losses. We're going to lose people we love. We're going to no longer be able to engage in activities that give us pleasure. And we may not be able to live where we used to live. And it's very natural to mourn these losses.
So what is grief? A complex response to loss or the threatened loss of a loved one. A person may also grieve the loss of a thing or a place to which he or she is attached, a change of home, inability to participate in an activity or work. And grief and grieving can be prolonged and complicated. You know, like with the situation with Louise, you know, she was grieving for the loss of her home, her caretaker, she knew her life was ending soon, and it took, she went through a process of, you know, sadness, anger. You know, we had to sit with her and work through all of that to make her comfortable with her loss that was imminent.
Don't overlook or minimize the person's grief process. Individuals with intellectual disabilities are as vulnerable to mourning and feelings of sadness as anyone else. And they may struggle with understanding what has happened and may take longer to process the comprehension that a loved one has gone. I worked for a long time with a man who was he was very bright. He worked independently in the community, and his dad had passed on when he was fairly young, and his mother lived into her 80s, even maybe her early 90s. And when she passed away, he really struggled with understanding where she was. He spent a lot of time going to his church. He was very involved in a community church and talking to his minister about what had happened to his mom. It's important to give the person that space to do that. It's really normal for a grieving process to go on for weeks and months, and it's also important to support the person to honor those feelings and to kind of make accommodations for the person and speak frankly with them about what they're going through. You may want to refer the person for grief counseling. Linda's part of the Bereavement Committee at a local agency here, and I know oftentimes people are referred to you to talk about grieving issues. So people with IDD and DD may struggle to integrate the concept of loss into their daily lives. It may be hard for them to understand that this really happened. Many times the loss of a significant person disrupts the individual's whole worldview, and they may begin to feel like the world is no longer a place that's safe or predictable. So you want to be alert to the emotional changes that may signal that the person is really suffering. They may want to isolate themselves. They may have trouble sleeping at night. These may all be indications that the person is having a difficult time managing grief. At that point, you may want to call in someone to do some grief counseling. You may want to collaborate and refer to a healthcare professional, speak to the nurse who's working with you, and make sure that the person has the supports that are in place.
And the other thing is also supports for the people taking care of the people in your case. So for the caregiver, for the staff that have experienced the loss of someone that they've taken care of. There needs to be time to discuss with all of the people involved with that loss, not just simply the person experiencing the loss.
That's a good point. I know a lot of times people who have lived in a congregate care setting, when that person dies, it's really hard for the other people living there to just cope with the loss of that person who was so much a part of their lives.
It might have been their roommate, or it was a person that the staff person had a special relationship with and spent a lot of time with. And when they're gone, they're grieving as well and need time to express that.
It's important to keep in mind that bereavement can include multiple losses. The person may lose a caregiver, but that may also mean that they have to move, that they may need to have a different day service that they go to. They may be living in a different community. They may also experience a grief reaction over losing a common routine, of leaving old friends and needing to develop new relationships. So keep discussions going. Reach out to the person and talk to them about what's happening to them, how they feel. Reach out to the person's circle of support and their network for grief counseling or spiritual guidance. There are a lot of resources available, and it's important to look for those and to provide them to the person.
So common grief responses, the physical responses are fatigue, sleep and appetite disturbances, emotional changes, anger, anxiety, sadness, cognitive changes, confusion and disorientation, or social changes, withdrawal from friends, isolating yourself. Okay. You need to support the person, help the person understand the loss, encourage the person to take part in ceremonies and rituals to honor the deceased. Be aware that expression of grief can be delayed. The person may need time to understand the permanence of a loss, and especially someone with ID, the loss isn't experienced until time goes by, and they don't see that person anymore. They don't realize they're gone until they see they're going to their work site, they're going to their home, and that person is no longer here. And then they start to ask that question, what happened? And then they will grieve. So it could be months later that they're grieving, because it takes time to realize that loss happened based on the level of functioning of the person you're working with. Be aware that like I said, be aware that it can be a delayed response. Therapy can help. See a professional grief counselor trained in helping people with IDDD. Not everyone understands that the grieving process in someone with a cognitive problem, it takes them longer to comprehend what the loss is.
So in addition to grief, individuals may respond to aging issues, including dementia, with behaviors that are new and unusual compared to the typical ways of interacting with the world. It's important to take any behavior change seriously and to work with the person and with a circle of support, including healthcare professionals, to discover if the behavior is actually an attempt to communicate some sort of distress.
Behaviors may be how someone, change in behaviors may be how someone is communicating. Challenging behaviors are common for people with dementia. People with IDDD may not know how to communicate discomfort associated with common aging problems. Behavior may be a response to pain, depression, confusion, or some other issue. So you got to keep prodding those questions and looking at what's going on. If someone was, a very easygoing individual that was very socially appropriate, and all of a sudden they're throwing things across the room, there may be a pain that they're experiencing or a loss they've experienced, and they're not able to express it. So ask those questions. The person is often struggling to communicate a need or an attempt to change something in his or her environment.
Okay, how to cope with difficult behaviors. A great resource is from the Vermont Agency of Human Services, and it's put together a handbook that you can download, and it provides a comprehensive overview of how individuals respond to aging and dementia with behaviors. One of the most useful sections in this handbook is a discussion of common behaviors that individuals experience, and it provides step-by-step suggestions for understanding what the behavior means. And the focus of this is that you're not really trying to manage the behavior as much as you are trying to understand it, and to understand it in terms of whether it creates a problem or if it's really something that the person is trying to communicate. So you're not going to manage the person or the behavior. You're going to try to understand what it means. You're going to think about, what caused it? What were the antecedents? When did it happen? Is it something that happens every evening? Is it sundowner syndrome, where people with dementia often get very agitated in the evening? And then if you do provide an intervention, did it help? And then also, whose problem is it? Who's really affected by this behavior? Is it something that's just a routine of the household? Is it something that can be, accommodated if you change your own behavior? So if a person is very loud around 5 o'clock every night, does it help if other people put on earphones and listen to music, for example?
Hostility can be triggered by fear, anxiety, noisy environments, crowds, confusions. There are meanings to some behaviors. Hostility and aggression may be an attempt to isolate or express frustration. Agitated, attention-seeking person may need companionship or may be frightened, anxious, or in pain. Property destruction often is an attempt to self-soothe, like tearing paper is a way of soothing. You're disrupting others' activities, often a response to noise and confusion in their environment, and so it's a response back.
Sometimes a person becomes very resistant and doesn't want to cooperate with care. This may indicate, as Linda was saying, pain or discomfort. Wandering is a common behavior. This could be an effective medication. It could indicate restlessness. A person could also just be bored with the current environment. When we were talking about how to accommodate living situations, we talked about providing a safe space where the person can walk around and get some stimulation and do something a little more interesting. Hoarding and rummaging is another common behavior, and that can indicate a fear of loss or an anxiety. If a person loses interest or begins to isolate themselves, as we've talked about, that could be depression. It could also be a sign of the onset of dementia, and it's important to evaluate that. Delusions are often common with people with dementia, and you should be responding with reassurance and redirection, and you may want to refer for a psychiatric eval and maybe some medication to help. Any questions?
No questions at this time, but we do encourage anyone that does have a question to please either use the raise hand feature on your control panel or use the chat feature. Simply type it into your chat window. You can send it to me, Lisa Zimmerman, directly, and I will make sure that Linda and Jill will answer the question during the next Q&A session. So, but at this point, there are no questions, so we can continue.
Okay. The final section of our presentation is coordination of diverse systems. We're going to be talking about how you can access resources. As we've talked about, you want to build a circle of support for the individuals that you're providing care for, but it's also important to build a circle of support for yourself. Find out as much as you can about current resources and research in your area, and share this with the caregivers and the individuals that you're working with. Talk to people who are doing the same job as you are doing in other states and in other regions of your state. It's good to problem solve with somebody who understands the challenges that you yourself may be confronting as a practitioner. Try to go to conferences and symposiums like this one that focus on aging and related issues. And these serve to really rejuvenate you and give you new ideas about your practice. And it also helps you to stay excited about your work. We've also provided a person-directed dementia care assessment tool. You know, if you do suspect that somebody is experiencing a decline in cognition, you can use this tool. It's not a diagnostic tool, but it is something that can provide some indications that a person is having some cognitive declines. And you can discuss this with other healthcare professionals in your circle as part of routine wellness visits, particularly if the results indicate that there are some kind of significant changes. And this can also be retrieved from the Department of Human Services at Wisconsin. Learn about local options. Explore residential settings in your community that might offer what's called progressive supports, and that would be supports that can be modified as an individual's needs increased. And they, would evolve in response to increasing needs. Find out if there are any caregiver networks in your area and become involved. And encourage the caregivers that you work with to become involved as well. Caregivers who are providing ongoing supports can become really stressed out. There's such a thing as caregiver stress and caregiver burnout. And having a circle of support for the caregiver can also really be helpful.
Develop relationships with other healthcare professionals. Network with other healthcare professionals who have a person-centered focus. Encourage them to participate in circles of support for individuals they serve. And build a team, a person-centered care team that consists of occupational therapists, physical therapists, social workers, nurse, hospice, doctor, and work, check things out with each other and discuss what your alternatives are, what kinds of things would help this person, what kinds of ways you could fulfill the wishes of that person. And DJ was a young man with cerebral palsy. He was nonverbal, but he was not intellectually impaired. He had a normal IQ, but he was non-ambulatory and ADL dependent. And his communication method was with a chatterboard or computer-assisted technology. He had scoliosis that was quite advanced. He ended up hospitalized, and during the hospitalization, hospital staff reported he couldn't communicate. We did share with them that he used a chatterboard, which when we went to visit, we found in the corner of the room, not accessible to him. And he was not able to, they were assuming that he was developmentally disabled and intellectually disabled and was incontinent, and he was quite upset because he wasn't getting a urinal, he wasn't getting help that he needed to use the bathroom, and ended up left to be in soiled bed sheets. When this was not normal for him, he was normally able to communicate his bathroom toilet needs. He had to be fed. People were not realizing how much help he needed. We would come visit, and his tray would be sitting there, ice cold. It was all jars of baby food, which was not something he normally ate. He could eat a normal diet. It just had to be chopped and fed to him, and he was quite upset. And it sort of taught us a lesson that each time hospital staff changed, you thought you had covered the fact that he was able to communicate with a chatterboard and was normally continent of his bowel and bladder and normally ate a chopped diet. Or if he was in pain, he was not able to communicate to anyone that he was, because he couldn't reach the buzzer. He couldn't use the buzzer that they had there. He would have to have a different kind of device because he only had a thumb and forefinger that worked. So he would have to have something that he could press against, not something to squeeze. He wasn't able to do that function. And every time we talked to one shift of staff, the next shift came on, the communication never went to them. No one ever realized that there was specific needs he had to be able to take care of him. Ultimately, we ended up working out that we moved him back to the community home he came from sooner, because we were able to take care of him there. We really never got through, as it just changed. His level of care was no longer met.
But I think that speaks to having a network of professionals who are person-centered and who would have taken the time to learn about DJ and what he needed. You want to stay informed about federal initiatives. We're living in changing times right now, and the supports and funding for people with disabilities, particularly people with intellectual disabilities who are aging, are very much in the forefront of federal supports at this time. So pay attention to the initiatives that are becoming available. I'm going to talk specifically about the Affordable Care Act, Olmstead, and I'm not going to talk so much about the waivers, but I am going to mention that if you are providing services to the HCBS waivers, most of them require that you do person-centered planning. One of the things about the Affordable Care Act that is sort of remarkable is that it identifies 10 categories of essential health benefits, and included in these are rehabilitation and habilitation services, as well as durable medical equipment such as orthotics and other devices like prosthetics. And the implications of this are significant because benefits can't be denied to somebody on the basis of his or her disability, and there's a focus on assuring quality of life. Habilitation is defined by Medicaid as services designed to assist people in acquiring, retaining, and improving the self-help, socialization, and adaptive skills necessary for them to reside in the community. So again, that supports aging in place. It's in line with person-centered planning, and it's really a valuable focus for people with intellectual and developmental disabilities. Olmstead is another issue that's very much in the forefront right now. It's based on 1999 litigation in Georgia. Two women were it was a psychiatric institution, an inpatient, state-run inpatient facility, and they actually brought litigation against the commissioner because they felt that they should be allowed to live in the community. This litigation went all the way to the Supreme Court, and it was decided in the favor of the two women based on the American Disabilities Act, and it says people who had mental illness or developmental disability could not be could not be, kept in a mental institution or a psychiatric institution unless there was actual justification for their continuing need of care. What emerged from Olmstead was an integration mandate for all state and local governments to provide services in the most integrated settings appropriate to the needs of individuals with disabilities. And states have been required to develop an Olmstead plan to put those, that transition of individuals from large congregate care facilities into communities in place.
The Olmstead Act is enforced throughout the country. The Office of Civil Rights investigates complaints that allege there is a violation of the Americans with Disabilities Act integration regulation, which states that people with disabilities are entitled to receive public services and supports in the most integrated setting that is appropriate for their needs. The impact of this has been significant for many people with disabilities, including those with IDDD. People who have lived in institutions for many years can now return to their communities, live in their own homes, and receive needed supports and services as a fully integrated community member. The above graphic demonstrates the number of Olmstead cases over 10-plus years since the Olmstead ruling. Total of 851 investigations with corrective action being obtained in 61% of the cases and no violation found in 39%. The Office of Civil Rights updates this information annually.
There are also Aging and Disability resource centers that have been created. It's a collaborative effort with the Administration on Aging and the Centers for Medicare and Medicaid, or CMS. These are local centers that can provide information to you or to other caregivers about resources and benefits that are available in your community. It includes information on benefits management and connection to wellness programs. You can find out where they are located in your community by going on the web, and you can just put into the search engine ADRC, and you should come up with that information. So in conclusion, we're going to talk about tools that you can use for implementing these supports. And again, I'm going to just review that foundation that we've been talking about with the Edinburgh principles. You're going to be trying to adopt a workable philosophy of care, adapt practices at the point of service delivery, work out coordination of diverse systems, and promote relevant resources. And you can do this through using the 4 C's: collaboration, partners with community groups, faith-based groups, local universities, and provider agencies. Communication, develop networks and circles of support, not just for the individuals that you're working with, but for the caregivers that you know about and for yourself. Identify health cares and professionals who are good listeners, advocates, and who use a person-centered approach, and teach them about who the person is so that if the person is hospitalized, they're being cared for by people who know them. Creativity, explore new ways to maintain the person's quality of life and personhood. Be really open to ideas and new suggestions, and take the time to discover new resources, and be a strong and purposeful advocate. Sometimes that's the most important thing. And commitment. Be proactive in researching and developing and accessing supports. Find out what's out there, find out what's going on, and try to get the best supports for the people that you're working with, for yourself, so that you can be a better practitioner. So we're going to move on to our questions.
And there are no other questions.
Okay, we do have some questions for you. We're going to move to our test.
Okay, most individuals, 75% with ID.
Oh, okay, so Lisa's going to set these up, and she's going to give us a heads up. Okay, Linda, you can drink your water. And
Thank you.
And Take care of yourself. Okay, the first question, because Linda's drinking, most individuals, about 75% with intellectual and developmental disabilities, live with family members. Is that true or false? And we're going to pause while you answer that question, and then Lisa will give us a heads up, and we'll move to the second question. You want to take this one?
Sure. Person-centered planning is not appropriate for aging individuals. True or false? Okay, this is false because what we've been focusing on all along is person-centered planning is the most appropriate for aging individuals. Include them in all the things that you're deciding.
I guess I forgot to say that the answer for the first question was true, that most individuals with intellectual disabilities live with family members. The third question, the Edinburgh Principles define practices for community supports for people. Is it okay to go ahead with that, Lisa? Supports for people with intellectual disabilities who are affected with Alzheimer's disease and or other dementias, but are also useful in designing supports for all individuals with intellectual disabilities who are aging. And is that true or false? Okay, we can go ahead. That should be true. And now, Linda, do you want to do number 4?
Sure. Individuals with Why is it true?
Why is it true? These are practices that were designed by a work group that convened in Scotland in, I believe, 2009, and they developed the principles that we've been talking about that really talk about how to design practices that will enhance community support. They were talking specifically about people with Alzheimer's disease and other dementias, but I think the principles are they're very comprehensive and broad, and they can be useful concepts for working with all individuals who are aging.
Okay. Individuals with IDDD should be excluded from participating in rituals and ceremonies associated with a loved one's death because they don't understand. True or false? Okay, that is false because talking about death and dying demystifies it. It allowing a person to participate in the rituals and ceremonies associated with a loved one's death helps them to cope with that death, helps them to understand that that person has moved on, and it avoids behavior problems with the individual.
Okay, mobility risks can be addressed through environmental modifications, including handrails and ramps. True or false? Okay, the answer is true. You want to provide supports to minimize fall risks and to also sustain a person's mobility as long as possible.
Ready? People with cerebral palsy are more likely to develop dementia than people with Down syndrome. True or false? Okay, that's false. It's people with Down syndrome that are have a higher incidence of going on to develop Alzheimer's or dementias. People with cerebral palsy are more likely to develop mobility problems as they age.
Hoarding and rummaging may be a common behavior for someone experiencing dementia. True or false? That answer is true. Someone with dementia may express feelings of anxiety or fears by hoarding and rummaging.
Okay. Individuals with IDDD should not be included in developing an advance directive because it is too upsetting. True or false? Okay, the answer to that is false because, yes, people should be included in their advance directives. Remember the 5 wishes. We want to talk about what someone wants and respect what their wishes are. And it is less upsetting to be a participant in planning what's to come rather than to be just have everything work around you.
ADRCs provide information and assistance about local resources for aging individuals. True or false? That answer is true. ADRCs are a collaborative effort between the Office of the Aging and CMS, and they provide local information about resources for individuals who are aging.
Okay. The Olmstead decision includes an integration mandate for all states. True or false? Okay, that's true because the Olmstead decision was specifically developed to integrate people into the communities.
Okay, we've included the answers for your information, and if you did get something wrong, you should be able to find the information in the PowerPoint, or I guess people can direct questions to Lisa at RRTI. And are there any questions or discussion? Okay, so we're going to move to the evaluation survey. Thank you for your time.
Hi, everyone. Once I close out of this webinar, you'll see that a survey will pop up in your browser. If you can, please answer the questions at this time. If not, no worries. You'll receive a follow-up email tonight, actually at midnight tonight, so you can take the survey then. If you already took the survey and still received the email, don't worry about it.